Hello viewers, my name is Dr. Rajiv. Welcome to my education channel, YouTube Surgery and Orthopedic Education. Today's lecture is on chondrogenic bone tumors. The link of the first part of the lecture series on bone tumors, including introduction, etiology, and discussion on osteogenic tumors, has been given in the description box. In the end, please subscribe to our channel and give us a like if you find the discussion useful. Also, don't forget to press the bell icon below to get my videos regularly. The bone tumors are classified according to the tissue of origin or the matrix they produce. The rest are grouped by clinicopathologic features. The majority of benign and malignant primary bone tumors are cartilaginous, means they produce cartilage. Most primary bone tumors are benign. Metastatic tumors are more common than primary tumors. An osteochondroma is popularly known as exostosis. It is the most common benign bone tumor. It is a cartilaginous neoplasm because it produces chondroid matrix. These typically occur in adolescent males in their second or third decades of life. The lesions are usually asymptomatic and are found incidentally during the examination of an extremity swelling. Osteochondromas can be pedunculated or sessile. Their size range from 1 to 20 centimeters. The stalk or base is always continuous with the medullary cavity. The cortex of the stalk merges with the cortex of the host bone, which is a characteristic radiologic feature. About 85% are solitary and sporadic, while the rest occur as part of hereditary multiple exostosis syndrome or diaphyseal eclasis. The hereditary multiple exostosis syndrome is an autosomal dominant condition with the mutation in EXT1 gene on chromosome 8 or EXT2 gene on chromosome 11. Osteochondromas develop only in bones of endochondral origin. The tumor is a cartilage-capped bony overgrowth which originates from the metaphysis near the growth plate of long tubular bones, usually near the knee. The most common locations of osteochondromas are distal femur in 30%, proximal tibia in 15 to 20%, and proximal humerus. It may also occur in pelvis, scapula, and ribs. The patient usually presents with a painless swelling around a joint, usually the knee. There may be similar swellings in other parts of the body in hereditary multiple exostosis syndrome. The tumor always grows away from the nearby joint, typically projecting away from the epiphysis and going towards the diaphyseal region of the bone. A rare variety of intra-articular epiphyseal osteochondroma is found in Trevor disease. This tumor is not a true neoplasm because its growth stops with cessation of the parent bone growth. The tumor is a result of an aberration at the growth plate, hence it may be called a developmental anomaly. There are several well-documented complications like fracture, infarction, bursa formation, vascular pseudoaneurysm formation, neurovascular compression, and occasionally malignant degeneration to chondrosarcoma. The features associated with malignant transformation are increasing size or pain, growth after skeletal maturity, cortical destruction, pain after puberty, and cartilage cap thickness greater than 1.5 cm. The rate of malignant transformation is less than 1% in solitary osteochondromas and 1 to 3% in patients with multiple osteochondromas. The treatment is complete excision, including the periosteum over the exostosis. The chondroma is a benign tumor of mature hyaline cartilage. They usually arise in the medullary cavity of long tubular bones from rests of chondrocytes, where they are called enchondromas. Rarely, they may also arise on the bone surface, where they are termed periosteal chondromas or juxtacortical chondromas. The phalanges of the hand are the most common location, but any bone can be involved. All age groups are affected, but these tumors are most often found between 20 and 50 years of age. They are typically solitary and arise in the metaphysis of tubular bones of the hands and feet. They are the most common tumor of the small bones of the hands and feet. They are also the most common intraosseous cartilage tumor. Chondromas are usually asymptomatic and are frequently discovered incidentally during a radiographical examination or after a pathological fracture. In a hereditary skeletal dysplasia known as Olier's disease, multiple enchondromas are found in large and small tubular bones and in flat bones. If there are also soft tissue hemangiomas and lymphangiomas, the condition is called Maffucci's syndrome. This clinical setting is known as enchondromatosis. In enchondromatosis, there is a definite tendency to sarcomatous transformation. On X-ray, chondromas are seen as expanding lytic lesions with intralesional calcification described as a stippled punctate or popcorn calcification. Overlying cortices are thinned out. Treatment is usually observation. An unsightly appearance is generally the indication for curettage and bone grafting. Tumors in the long bones, and when multiple, they are known to undergo malignant change. These patients must be monitored indefinitely for malignant change. Chondroblastomas are uncommon benign cartilage producing bone tumors. It characteristically arises in the epiphysis of a long bone in children. It is also known as Codman tumor. Bones around the knee are commonly affected. Patients experience severe pain and inflammation and sometimes joint effusion with restricted motion or muscle atrophy. Most chondroblastomas occur in proximal or distal femur, proximal tibia, and proximal humerus. Chondroblastomas are well-defined lytic bone lesions with bone destruction and thin sclerotic margins. On X-ray, there is a well-defined lytic lesion surrounded by a zone of sclerosis. Calcification within the tumor gives it a mottled appearance. Treatment is curettage and bone grafting. Chondromyxoid fibromas are rare, benign chondrogenic bone tumors that account for less than 1% of all bone tumors. These are most commonly found in the metaphysis of long bones. Patients are usually between 10 and 30 years of age. Presenting clinical features are regional pain and swelling. Males are more commonly affected than females. The classical anatomical location is the upper one-third of the tibia. On plain radiograph, tumor appears as an oval eccentric lytic lesion with well-defined sclerotic margin and long axis parallel to the long axis of the affected bone. Treatment is usually intralesional curettage plus bone grafting or PMMA cementing. Chondrosarcomas are malignant cartilage-producing tumors of varying aggressiveness ranging from very low-grade lesions to highly malignant dedifferentiated tumors. They are the second most common primary malignant bone tumors after osteosarcoma. Patients usually present with long-standing deep pain and or a gradually enlarging mass. Patients are usually between 30 and 60 years of age and men are affected twice as frequently as women. Children are rarely affected. Chondrosarcomas commonly arise in the axial skeleton, especially in flat bones such as scapula, pelvis, and ribs. They may also arise in metaphysis of the proximal femur, proximal humerus, distal femur, and proximal tibia, but distal tibia and distal humerus are rarely affected. Primary chondrosarcomas arise in heteronormal bone, while secondary chondrosarcomas arise in pre-existing lesions such as osteochondromas or enchondromas. There are four histological types: conventional chondrosarcomas, clear cell chondrosarcomas, dedifferentiated chondrosarcomas, and mesenchymal chondrosarcomas. The conventional type is the most common. The clear cell and mesenchymal variants occur in younger people in their teens or 20s. The clear cell variant is unique in that it originates in the epiphysis. Dedifferentiated chondrosarcomas are highly malignant. Over 60% of chondrosarcomas show mutation in either IDH1 or IDH2 genes. On radiographs, chondrosarcomas appear as intraosseous osteolytic tumors with mottled calcifications within the tumor matrix, described as honeycomb or popcorn calcification. There is erosion and destruction of the cortex also. CT is more useful for demonstrating matrix calcifications and bone destruction. Accurate differentiation of low-grade from high-grade chondrosarcomas before surgery can be done with MRI. Full staging of tumor before biopsy requires X-rays and MRI of the entire bone affected. Distal staging requires bone scan and chest CT. Diagnosis is confirmed by biopsy. Surgical excision is the only treatment because chondrosarcomas are resistant to both chemotherapy and radiotherapy.